Hello, good morning, good afternoon, and good evening to all our speakers, chairs, and the wonderful audiences in different parts of the world. Welcome to ACNS webinars. The speaker for the first session of today is our honorable guest from the USA, Professor Hamid Abbasi. Professor Abbasi is a Chief Medical Officer at the Inspired Spine, board certified neurosurgeon, and internationally recognized expert in minimally invasive spinal surgery. He earned his MD from Heidelberg University School of Medicine, and after completing his residency in neurosurgery, he went on to complete a fellowship in neurosurgery at the University of Texas Medical Branch at Galveston. He is a pioneer and internationally known neurosurgeon in advanced minimally invasive spinal services. He is an accomplished surgeon with remarkable technical skills and cutting-edge knowledge in minimally invasive spinal procedures, including the revolutionary oblique lateral lumbar interbody fusion procedures. He is the first of the 30 surgeons in the United States performing OLLIF procedure to publish a clinical study on OLLIF outcomes, which is also published in the National Institute of Health Index. He developed advancements in MIS procedures for improved access involving both lumbar and thoracic regions of the spine. He was trained over 23 years at some of the world's most prestigious medical institutions, including Stanford, Dartmouth, and University of Texas. He is focused on educating and training surgeons in the advancement of MIS spine surgeries for increased patient accessibility to a higher level of care. We are extremely honored to have him today with us, and today he will be talking about variations of transcutaneous approach in the thoracolumbar spine and sacroiliac joint. The speaker for the second session of today is our very honorable guest from China, Professor Huang Yabo. Professor Yabo Huang is a consultant neurosurgeon and director of Cervicocerebral Revascularization Center, the first affiliated hospital of Suzhou University, China. He graduated from the Suzhou University with a doctor's degree in clinical medicine. He mainly engages in clinical and basic research in cerebrovascular diseases. He specializes in techniques about intracranial to extracranial bypass surgery, and he is an expert in treating various cerebrovascular diseases and has performed over 3,000 complex cases, including aneurysms and AVMs. We are extremely honored to have him today with us to be a speaker at our webinars, and today we will be talking about microsurgical management of extracranial internal carotid artery aneurysms. The chair for the first session of today is our very honorable faculty from Turkey, Professor Mehmet Zileli. He has been the founding president of the spine section of the Turkish Neurosurgical Society, president of the Turkish Neurological Society till 2008, president of the Turkish Neurosurgery Board till 2012, president of World Spinal Column till 2014, president of Middle East Spinal Society till 2015, and president of Asia Pacific Cervical Spine Society. He has organized several international and annual congresses of several important neurosurgical societies, including the ACNS. He has important contributions to education and training of spine surgeons in Turkey by organizing several courses on spine surgery, and he has also been the host of the Traveling Fellowship for the Spine Society of Europe. He is the founder of the first Spine Fellowship program in Turkey and served many national and international fellows. He is a noted author with several book chapters and over 800 citations. We are extremely grateful to him for accepting our invitation to chair the first session of today's webinar. The chair for the second session of today's webinar is an honorable faculty from Japan, Professor Hidehito Kimura. Professor Kimura is a consultant neurosurgeon at the Department of Neurosurgery at Kobe University, Japan. His clinical interests are focused upon management of complex cerebrovascular diseases and is one of the most sought after faculty for ACNS workshops for cerebrovascular bypass surgeries. He is also a noted author with several publications in various peer-reviewed journals. We are extremely grateful to him for accepting our invitation to chair the second session of today's webinar. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to welcome both the speakers, chairs, and the wonderful audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely grateful to Professor Shubing for broadcasting this webinar on the WeChat channel. Dr. Liu Bun Seng from Malaysia is my co-host for today. And with that introduction, I would like to hand over this podium to our first chair, Professor Mehmet Zileli.
Hi everybody, it's my great pleasure to be with you, and I'm very honored to...
I think Prof. Abbasi, you may take over since we cannot hear Professor Zileli.
Okay, well, first of all, thank you very much for the warm introduction. It's always an honor to be part of this great educational event. I'm going to talk today about the variation of transcameral approaches to thoracolumbar spine, and as well at the end, I'd like to talk a little about sacroiliac joint fusion. And these are variation of approaches that are all percutaneous. And I think the most important part of that is that you do not need for these approaches a direct visual understand a direct visual view of the anatomy. They're all performed percutaneously. So this is my disclosure. Now, according to Lancet, spine is #1 reason for disability worldwide now. Even about 30 years ago, spine was #2 and later #1 reason for disability in the United States. But it seems that globally, spine, and I'm always including sacroiliac joint in the spine, is now the #1 for disability worldwide. And we have to understand that spine is a common problem, especially in elderly. By the time you are 50 years old, there is only 31% chance you won't have spine problem. But by the time that you are 70 years old, there is only 1 to 2% chance that you do not have spine problem. So we are talking about something that is extremely common. And obviously, I understand that, especially in the neurosurgery, we deal with lots of different pathological situations. But even in the most busy neurosurgical department, 70% of the procedures are on the spine. And considering that neurosurgeons are only one faculty, one area of the medicine that we deal with the spine, and our orthopedic colleagues deal with a lot more, that we have to understand that the spine is a public health issue. Now, not all the spine pathologies need surgery, and we are able to help a lot of patients without surgery, and not every spine situation that requires a surgery requires a fusion. Many of the situations we deal with can be addressed with decompression alone. I'm referring to the picture on the upper right side. A simple decompression there, macrodiscectomy, foraminotomy, laminectomy are still very valid operation. But in certain situations, especially imagine when I talk about the disc, intervertebral disc, I'm always comparing it to a tire of a car that cushion the car against the road, it cushion two bones against each other. In certain situations, like when your disc look like the tire on the lower right area, certainly the fusion is a standard way of us treating that. Obviously, we're developing additional methods like an intervertebral disc, but fusion still is the standard of care. And these procedures in the number are definitely increasing. This is the data from the United States. Becker Spine Review has reported that there are 1.62 million instrumented spinal fusion are performed in the United States annually. I mean, this is a staggering number. This is, as a matter of fact, the most performed procedure in the United States. And the rest of the world is actually catching up with us. Every time I am in another country, I hear that their number of spinal fusions are increasing. In the United States, though, still more than 75% of these procedures are performed in a traditional way. And certainly, there is a good legitimacy for different approaches to treat the spine. But I'm going to present to you another tool in your toolbox. This does not practically make all the other tools that you will have in your repertoire, in your toolbox, unnecessary. This is just an additional tool that gives you additional advantage in certain situations. So, and I need to emphasize that the difference between MIS and percutaneous OLLIF, the procedure, is not the size of the skin incision. It is not about the skin incision. I have to repeat that numerous times. It is about the activities that you do under the skin, especially that you are not destroying paraspinal muscle, you are not stripping the muscle of the bone, and you are not disrupting vascularization of the bone. This is what gives the patients advantage of this procedure. these are paraspinal muscle. We understand these are multisegmental, and even in a small procedure, in a traditional way, you're stripping all this muscle from their origin. We know when you strip this muscle from their origin, you're practically making this muscle inert, inactive, and non-functional. And these are going to be affecting multiple levels. But I think one of the most important thing in that minimal invasive is that you are not disrupting the feed loopback mechanism of the muscle, and you are not disrupting the autoregulation of the muscle, because in a surgery that you are cutting the tendon, and in most of posterior traditional spinal fusion, you are literally cutting the muscle from their origin. As a matter of fact, you are removing their origin, which is the lamina and spinal process, and practically rendering that muscle physiologic, not only inactive. Next day after the surgery, muscle does what it does. It contracts and it never gets a feedback that it's enough. This patient takes a long time to ambulate. And as a matter of fact, we found out that with any muscle sparing technique, patient ambulate tremendously faster and return to the activities a lot faster as well. The studies from 1937, which shows the vascularization of the bone is through surrounding muscle. We all know as surgeon, you never have an artery of L4 or artery of L5. The vascularization of the bone is through surrounding muscle, and by stripping this muscle from the spine in a traditional surgery, as a matter of fact, you're reducing the vascularization of the bone to a 25% of the original value. I want to repeat that because I think it's really important. In a traditional surgery, because vast majority of the vascularization of the bone is through posterior paraspinal muscle, when you are performing a TLIF or PLIF, you are stripping the muscle of the bone and you're reducing the vascularization of the bone to the 25% of the original value. And that makes sense now that this patient have difficulty for the bone fusion. This is a patient of mine. In 2012, I did a 2-level TLIF, and on the left side, you see scar from that. This same patient had adjacent segment disease. In 2014, I performed the OLLIF procedure. Unfortunately, this patient had an accident in 2016, and I took the patient back to revise everything because after a motor vehicle accident, literally, the patient was having hardware and spinal fractures. And this is how you see the picture that where I did the open previous surgery, all the tissue is scar. And on the right side, you see where I did the adjacent segment OLLIF procedure. We are dealing with pristine tissue. As a matter of fact, we all know when you even go 6 months after your surgery, traditional surgery, you don't see really anatomy anymore. Everything has turned into scar. Whereas here, as you see in the OLLIF area, practically everything is pristine, perfused tissue that can help patient with the healing process. This is an MRI of the traditional spine surgery. As you see here, we are dealing with all the paraspinal muscle that are turned into scar, whereas normal muscle look like that. This is a patient of mine. I did a L4-5 TLIF procedure. And as you see, if not only in the area that we did the surgery, muscle has turned into scar, but I pay attention to the upper right picture. The multifidus muscle level above has turned into scar, as you see in that area. Now, one of the advantages of percutaneous procedure, especially OLLIF procedure, is that it saves you a lot of time. But the impact of the time of the surgery, meaning the time patients on the anesthesia alone, is an independent risk factor. As a matter of fact, this study that you see here shows that every additional half an hour on the anesthesia adds 17% to the combined risk of the surgery. The reference is below. Please take a screenshot of it. If you get only one thing from this presentation, it should be this, that in this study says, if you put all your surgeries that are more than 2 hours in one group and all of those that are under 2 hours in another group, you are literally doubling the complication rate of that surgery. And this has been proven again and again, and as well as important to understand, this study had 388,000 data point. This is a meta-analysis, and they found that just the time on the anesthesia is an independent risk factor, and this is across the board for any kind of surgery. Now, I want to emphasize that, number one, if this is across the board, for prone position, this risk is actually higher. And as you know, most of our traditional spine surgery are performing prone position. And number two, this is not about advocating to be fast or cutting corner in the surgery, because any approach that in any approach that you cut corners, you're undoing any benefit that you would get from being faster by not doing the appropriate steps that required to make that surgery safe. This is just says, if you perform the same surgery in half of the time, you're getting a lot less risk associated with that procedure. And that is a situation that all of us surgeons are really familiar. And efficiency, for the same reason, efficiency for all of us is a cornerstone of our practice. And but we have to achieve that efficiency in a natural, organic way. And quite frankly, by not needing to cut the muscle, stop the bleeding, burning the tissue, and then going layer by layer, that sort of gives the OLLIF procedure a huge advantage. As a matter of fact, whereas in open traditional surgery, it literally takes you almost an hour to be at the disc level to start the actual surgery. In OLLIF procedure, within minutes, you are in the area that you are going to do the surgery in the disc space. This picture shows different approaches in the spine. This is a prone situation, and we are all familiar with the PLIF, which has been existing since 1950s. In 1980s, we started doing transforaminal lumbar interbody fusion, or TLIF, and 50 years we have been doing a lot of ALIF procedure, and we are very familiar with that as well. And for about 20 years, we have been doing OLLIF, ATP, or OLLIF, where patient is in lateral position. And as well, I'm sure most of us are familiar with true lateral approaches like XLIF and DLIF. Today, I want to only talk about the oblique lateral posterior lumbar interbody fusion, or OLLIF, which is very distinct from OLLIF ATP, and a variation of OLLIF we call MIS DLIF. This is practically a prone lateral approach. This is not the transcamin approach, the prone lateral approach that I use as a rescue if transcamin approach is not available, but it is done with the same instrumentation. I think that's what's important, that you can choose with the same setting and same instrumentation either to go transcamin or trans-psoas. This is more or less the terminology that says what I mean by oblique lateral posterior lumbar interbody fusion, a term that has been established since 2010. And certainly, OLLIF Awake is another approach that Dr. Varun Agarwal, my good friend, has been a master of. Now, there is a variation of the transcamin approach that is fully endoscopic. As a matter of fact, I think there's only 3 ways, literally, to respect the nerve root and anatomy in this area. Obviously, when Dr. Varun Agarwal, my good friend, is performing this Awake, the patient is your neuromonitoring that monitors the patient. And in CALIF, the endoscope, literally in the Cambin triangle, visualize the nerve and help you to avoid injury to the nerve. The way I do it with the OLLIF, I use 2 C-arm and neuromonitoring, and that is the method I'm going to present to you. And these are the 3 ways to avoid neural injury. There are some additional, variation that have been discussed in literature, and some our colleagues have been popularizing them. But I can just talk about my approach for you. That is a good solution if the efficiency, especially in elderly or patient with comorbidity, is an important factor. As a matter of fact, we perform these surgeries now, very complex surgeries, 3-4 level fusions under 2 hours, and mobilize and discharge the patient same day and in our surgery center. Certainly, if the lordosis is an important factor for you, the variation of ALIF or OLLIF ATP is a good option. And if in many cases you do need to do a direct decompression, TLIF and PLIF still are a must tool in your toolbox. And at the end of the day, I want to emphasize as well my good friend Dr. Myocardial slide that I have with his permission, that it doesn't matter really what procedure and you're a master of and so on. There is a sweet spot about what's actually important for the patient, where your mastery of your technique, what you have available and what patient needs, they have to come together. And often people ask me about pathology online in my personal chat, and please join us. We have a ACNS society where lots of us share information. My first answer to them is what procedure they should perform is, what procedure are you most comfortable with, especially in a difficult situation. You don't want to have a practice and have a difficult case in your learning curve. You should the best procedure for the patient is as well the procedure that you are best at your peak, and where you have all the resources in your location for that patient. Now, this slide is about 6 months old. As of just yesterday, where I did my last case, OLLIF case, my latest OLLIF case, we have done over 2,196 cases, and that is the result I'm going to present to you. And certainly, you know, I have done a lot, and that is what sometimes I think a misconception. I still perform open traditional surgeries. I still perform many surgeries that are not OLLIF. But the reason I go around the world and talk about the OLLIF is because I have no advantage to all my colleagues for ALIF, TLIF, and there are lots of experts there. But I'm just going to talk to you about the transcameron OLLIF, because we have performed over 2,000, almost 200 cases, and we know all the risk profile of this procedure that I want to share with my community. And as well, I want to show you that this is based on 15 years of information gathering, and I have over 48,000 follow-ups on this patient. So we have gathered a lot of information for this patient. This is solid data that I'm presenting to you. Based on this data, about 40% of these even complex surgeries are done under 1 hour, and more than 95% of them performed under 2 hours. Why is that important? Because now all of a sudden we are able to perform these surgeries in a surgery center. And with this, I don't mean just, one-level microdiscectomy. I'm talking about the 4-level fusions. I think considering that many of these patients are elderly and the cardiovascular capacity is limited, being able to have a shorter surgery with literally 1/10 of the blood loss give you a lot of opportunity to help a lot of elderly patients and keep them on their feet. This is how a regular surgical day look for me. Just 2 days ago, this Wednesday, I did 7 surgery, and we all got done at 5 p.m. And again, I'm not advocating to be fast. I'm just telling you what the natural profile of this surgery is. Sometimes you need a car, sometimes you need an airplane. An airplane doesn't cut corners to be faster than driving a car. It is naturally faster. As a matter of fact, a slow airplane would be a dangerous airplane. And that is what I'm trying to tell, that you can be more efficient, not by cutting corner, but having a procedure that by literally does not have to do the steps that are required in a regular non-muscle sparing technique. Our study shows that whereas in the blue line, as you see, where BMI goes up, the time under anesthesia goes up, and so the risk that directly correlate with that goes up. In a traditional surgery, that blue line, you see that how the time of this under anesthesia goes up. As a matter of fact, our society recommend not to do elective fusion with BMI above 40. The red line, it's important to understand this is about 400 cases, all the spinal fusion from 1 year in one hospital. Multiple surgeons are performing TLIF, as you see the line. Then there is a master of MIS TLIF that performs, has performed over 2,000 MIS TLIF, is a good friend of mine, very good surgeon. As you see in his hand, a very experienced hand, after BMI of 37, MIS TLIF is actually becomes more lengthy and more complication-ridden than a regular TLIF. And people who perform that, they know and understand that very well, that at certain BMI, you better do a regular TLIF, not a MIS, because it becomes exponentially more dangerous. Now, the green line is transcamin OLLIF procedure. As you see, it keeps the edge, especially in the higher BMI. And our next study showed that even up to BMI of 60, we could perform this surgery not only safely, but almost with the same performance in multi-level cases. Now, I think this is very important to understand that this is a slide that you should take with you. It's not about that you're faster in the surgery and more efficient in the surgery. It's about that this patient, 96% of them ambulate within 24 hours. Why is it important? Because we know non-ambulatory status is what's causing you lots of problem down the road, and it's the effect of the surgery itself. So practically, whereas in open traditional surgery, only 5 to 10% of the patient ambulate within the first, independently ambulate within the first 48 hours. In a transcamin OLLIF, 96% of the patient ambulate within 24 hours. So this is currently the situation in the spine. Pay attention to the upper bar. There is in the United States less than 2 to 3% of the lumbar spinal fusions are performed in a surgery center, the green part of that bar. Certainly the blue part shows lots of different kind of surgeries that we perform in the hospital, lumbar fusion on complex cases, but pay attention to the red part. There's a lot of patients we cannot help. And certainly it's important to me that we can expand the green area, and all of a sudden we can do 3-level fusion on lots of patients in our surgery center. But see that we can help a lot of patients. Until now, we tell to the patient, you need a surgery, but with you being older, with you having a high BMI, with you having comorbidity, surgery is just not safe for you. Now, all of a sudden, we have a tool to help them. As a matter of fact, just 2 days ago, one of my cases was a 4-level fusion, a patient that drove 9 hours to come to a hospital in rural Minnesota, because rightfully local surgeons have told him, you cannot have a regular surgery because a patient has a high BMI of 48 at a significant pulmonary and cardiac issue. We did that surgery literally in under 1.5 hours, and patient's already discharged. What I want to emphasize as well, that you do not need a $6 million investment to perform this surgery. Literally, what you see in this picture is exactly what you need. And I want to go over the steps of the surgery before I show you some pictures of it. On the very left side, I'm sure you are able to see my cursor. We have a neuromonitoring probe. This is a crucial part of this surgery. Certainly, you can use an endoscope so you see the nerve root, or you can keep the patient awake. That patient will tell you if you're close to the nerve root. But in my surgery, patient is sleeping. I have 2 C-arms, and this neuromonitoring probe is insulated all the way to the tip, and it has a metal sleeve over it. We have electrodes in major muscle groups in the lower extremity, so we can literally know if we are close to them. We stimulate with 3 milliamp, and then once we are in the Camin triangle, I go actually up to 4 milliamp. If I'm good at 4 milliamp, our study shows that I am about 5 to 5.5 millimeter away from the nerve root and the ganglion, and that makes the surgery safe. At that point, the sleeve slides down, and then the tube actually comes out. I will show you an X-ray to show that. Then through the sleeve, a K-wire, a regular K-wire goes inside of the disc base. Now we have an approach, a trajectory from the skin to the disc base. A dilator, the third instrument from the left, goes over the K-wire. It opens up this space, and it literally, I show you in the video, that by going inside and opening up the disc base, it pushes the nerve root up cranially and make that Camin triangle bigger. Then a tube, you see that here, a tube slides over the dilator and give you an approach from the outside of the skin to the disc base. Inside of that tube is 8 millimeter. The outside of this tube is 10 millimeter. We use hammer and a barrel, a mallet and a barrel, to hammer this tube inside of the disc over the dilator, and then we use a series of tools that start with a drill, with a rotating thread, a long pituitary, a disc cutter, and an articulating rake, perform a discectomy. And I can tell you, like any other instrument, you need about 10 to 20 cases to really get used to this. But the advantage here is that they all go inside of the tube that's 8 millimeter and are beautifully performing the discectomy, prepare the end plate. And in many cases, initially I put the endoscope in, I looked at the bleeding edge of the bone. But after about 50 cases, or actually 45 cases, I noticed that I can feel in my hand when the metal is hitting the end plate, the high frequency vibration that you feel in your fingers when you are performing the discectomy is, in my opinion, way superior to putting an endoscope in and looking at the bleeding edge of the bone. And you all have had, that experience that when you put your curette and the cartilage is gone, and all of a sudden you feel that how that the feeling, high frequency vibration feels in your finger. At that point, once I'm done with discectomy and preparation of the end plate, I put biologic in the disc base, and initially I used a PEEK cage, but now I use titanium cage, and here is my table. I think many of our colleagues are really surprised that how little instrumentation do you need to perform this surgery. This is all you need. Now, obviously, we have been having this available for last 15, 17 years here in the United States, but I'm ashamed to say that everything is so expensive in the United States. So this has not been available to the rest of the world, because the rest of the world, most of the rest of the world cannot pay American prices. Within the Avicenna Society, I'm proud to say that we have donated all our intellectual property to Avicenna Society, through Avicenna Society, to local Indian company, and these are all being produced in India now successfully for local market and for global market. So if you're interested, just connect to me. I connect you to that Indian company. We have no financial, I myself in the United States in that, but this is now available to all of you worldwide. So, and this is how my OR look like. As a matter of fact, the first table, you see the trans-Camin approach OLLIF. This is the second one, is the back table, and half of those instruments in the back table you don't really use. I want to emphasize, in my surgeries, I don't use Bovi, I don't use bipolar, I do not use suction. The way I calculate my blood loss, I weigh the sponges before and after use, And by subtracting the dry weight of the sponge, I calculate my blood loss that are often in tens of cc's. Please come and visit us. Explaining this on the slide is one thing, and experiencing in life and seeing these surgeries another thing. Please come and observe us in the United States. As a matter of fact, in about 3 weeks, I will be in Bareilly, in Karat, and in Chennai. In all 3 locations, we have live surgeries, cadaver lab. Please come and join us there. We would be honored to have you there as our guest. So let's look at some X-ray. I think that is sort of shows what we have been talking about in X-rays, in intraoperative X-rays. Now the surgery here, you see the ischemic spondylolisthesis, and I'm not going to talk about indication of the surgery because I think that's a different conversation. I want to talk about the performance of the surgery itself. And first, I use 2 C-arm. I think it's important. I will show you how the setup is. And in the first 200 cases, we just have been trying to find out what the best position of these 2 C-arm in the war, so they are not in your way. But what I'm going to start showing you is that after we get the true AP and lateral of this, I draw the trajectory of the disc on the skin in both AP and lateral. First thing I do, this is the trajectory in the lateral. And then first thing I do, I put a Jamshidi in one of the bones and I get some bone marrow and I mix that bone marrow with my biologic. In my case, is a tricalcium phosphate. We can talk about it, why I choose that. And I mix that with bone marrow, and that makes that the biologic a lot more effective for you. So here we are starting the surgery at 5:21 p.m. And then this is the probe that takes you to the Cambion triangle. I aim for the pedicle of the level below, then I go in and I then dilate, and then you see how the configuration of the spine changes when the dilator is inserted. This we call physiologic decompression, and we have a paper that we have published about the efficiency of so-called physiologic or indirect decompression to remove the symptoms. You see how the air is sucked in. And here are those tools that we talked about and to perform a discectomy. Then we pack the space with biologic and then take the tube out. A K-wire is put back in. And as you see, the cage is inserted. We are now at 5:27. If you remember, we started that surgery on 5:21. 6 minutes later, the cage is in. This is the efficiency of this procedure. Now, obviously, we have to put screws in, including, K-wires and screws in the level above and below. This is a tool that we use as well. You just quickly saw it, that we go and grind the surface of the facet with a special tool, and we achieve as a posterolateral fusion. Now, here you see that the rest of the surgery is all percutaneous. The 4 screws are put in, and the rod is inserted. Now, on the right side, you see that literally at 5:43, so this is the final picture of the surgery. So we started the surgery at 5:21. At 5:45, about 25 minutes later, we have the final picture, and then we spend a few minutes on closing the small hole. So the efficiency of this procedure is really unparalleled. And this is like another surgery that I'm showing to you here. And actually, this is the same surgery you just observed. That this surgery was the operative time was 24 minutes. Now, again, when I started this surgery, it took me about 180 cases to fall below 1 hour for 1 level fusion. Everybody who adopt our protocol falls under 10 to 12 procedure under 1 hour. This is what I'm really proud of. By us gathering our knowledge and passing it on to our colleagues, they are becoming efficient as I am, 10 times faster. And I think that is the value of adjusting your approach and gathering your knowledge and passing it on. Everybody who starts this now is going to be more efficient than I am in much shorter period of time, because they don't have to make their own learning curve. They can just add to my learning curve by adjusting our protocols, and I'm happy to share them all with you. So let's now go to the next slide. So this is the anatomy of the Cambin triangle. As you see, we have the exiting nerve root. One of the things I learned in my first 150 cases is that I don't freehand Cambin triangle. I aim for the pedicle of the level below under neuromonitoring, and then I stay on the periosteum and then slide down in the Cambin triangle. That has been very efficient to avoid multiple passes through the Cambin triangle that is directly related to the rate of nerve injury. This is the setup of the OR with two C-arms. Certainly, two C-arm can be a problem as the resources are sometimes hard to find. But I do, again, I can do 5 to 6 to 7 surgeries in one room with these two C-arm. So each C-arm goes a longer way for you and make you a lot more efficient. This is the setup in the OR. This is for regular cases. It took us literally as well about 250 cases to identify the best, most ergonomic, advantageous setup in the OR. There is another setup, and it looks the same, but it's very different, that I use in scoliosis cases, and that is because then you need all of a sudden maneuverability of these different C-arms. With the previous setup, they will come in each other way, the AP and lateral C-arm. With this setup, where the lateral machine comes still above the patient, but at an angle, it gives you a lot more maneuverability during the surgery. So let's look at some pictures. We have a patient in prone. I get in the same position, AP and lateral view, and here I usually aim for the middle of the disc. This was our original approach, that we aim for the 2/3, but now we aim for the middle of the disc in AP and lateral. We mark it on the skin. This is the neuromonitoring probe. Literally, we dilate over the neuromonitoring probe. Over the K-wire that is put in. Then we'll create a cavity with a drill. And this is the amount of the disc you can take out. Once you get used to this instrumentation, you do a great job at doing discectomy because you feel more comfortable. This approach is through a tube. That tube is protecting surrounding tissue from this sharp instrument that you go in and out. You don't hesitate. I can go 50, 100 times with this sharp instrument through the tube and be sure that the surrounding tissue are protected. So this animation as well shows the step of the surgery, and I'm going to run it just for a few minutes. So obviously we are now familiar with the Cambin triangle, and then once we position the patient, do the marking, we use a neuromonitoring probe with the electrodes inside in the lower extremity. We know how close we are. We mark the middle of the disc in the AP and lateral. And as you see here on the lateral picture as well, I literally draw the trajectory of the disc. And halfway between the center of the disc in the AP and lateral, that is where it takes you at 45 degrees to the Cambin triangle. And this practically, you have to be equidistant to the center of the disc in the AP and lateral. And here you see a direct approach to the Cambin triangle. I don't do that anymore. I hit the pedicle of the level above and drop the probe directly on the bone. Here, though, you see, we found out if you are good at 3 milliamp, you are about 4 millimeter away from the nerve root, 3.5 to 4 millimeter. But if you are good at 4 milliamp stimulation and you don't get any signal from the legs, you are literally 5 to 5.5 millimeter away from the nerve root. I can give you the profile, what is nerve root irritation risk or nerve damage risk is afterward. Now, we dilate now over the K-wire. And again, at every point, I have AP and lateral pictures that enable me to see the tip of my instruments. We then hammer the tube in. And then at this point, we create a cavity with this drill. And you see how by pivoting, you can have a larger area covered. This is a very special tool that goes over this, go inside of this 8mm tube, and then it opens up and help you to, we call that rotating curette. It then opens up, and by doing that, not only perform the discectomy, but there is marking there that it tells you how big of a disc, intervertebral disc device you want to put in, practically what the height of the cage would be. This is what we call a ring curette. It has a nitinol blade. It goes unilaterally up and literally cores and remove the disc material. Now, I pack the space then with bone marrow saturated biologic. The tube comes out. And now here you see a peak cage in the animation, but for the last 8 years, or actually last 7 years, I have been using titanium cage. And then that get put over the K-wire and then hammer and malleted in place. And that you have the final positioning of the disc device. Now, I'm going to now move on to next slide and show you that the learning curve of this procedure is about 20 cases of 40 levels, which is very comparable with every other procedure you learn. As a matter of fact, it seems that human brain needs 20 to 40 exposure to any complex act to learn. I'm a private pilot, meaning I'm a pilot here in the United States, not a commercial, but a private pilot. And FAA, Federal Aviation Administration in the United States, requires you 20 landing and 20 takeoff before you can have your license. It seems that our brain needs 20 to 40 exposure for any complex thing, and this is no different. What I can tell you that if you just do the first few cases with the proctor, and that's it what I do. I just was in country Georgia, not the state Georgia, and in Turkey, obviously. We were very honored to be in Turkey. What a beautiful country. Before that, we were in Georgia, and we helped one of our surgeons with the first 6 cases. You can condense these numbers by having a proctor with you in the initial learning curve. So I would like to, at this point, just stop and see if there is any question I may answer before I spend just a few minutes, maybe less than 5 minutes, on the sacroiliac joint. By the way, I'm very proud to be doing live sacroiliac joint fusion in India with a Trident system that as well will be available in India and the rest of the world soon. But before I go to my sacroiliac joint presentation, I want to just give an opportunity to see if anybody has a question I can answer.
You can present the other.
Okay, then
well,
let me just sacroiliac joint. I'm going to not spend too much time on that, but I want everybody, especially younger generation, to know, even in almost any practice, if you get 100 patients that coming to you for back pain, you have to be prepared. You have to understand that 22% of this back pain are not spine-based, but they are sacroiliac joint-based. And if you get 100 patients in your practice who had previous spinal fusion, studies are very clear. You get 100 patients who got the L455S1 fusion, and they still have back pain. This 43% of them are sacroiliac joint pain. And I want to emphasize that because since I have adopted sacroiliac joint in my practice, then I have 1/3 to 1/4 number of the failed back syndrome. Many of these, so what we call failed back syndrome, neglected and misdiagnosed sacroiliac joint. We do a beautiful surgery. And sacroiliac joint is nothing but the adjacent segment to L5S1. And then when they come back, we look at our construct, we look at everything is fine, except patient still have pain. And I want to emphasize to you that this patient, when they have pain, the pain is identical to the spine. I will show it to you at the distribution of the pain. And then we sort of just misdiagnose it or not diagnose it, and this patient go and have pain for years to come. So sacroiliac is one of the strongest joints in our body. It has to carry all weight. It is, as a matter of fact, it has a joint that has only 4 degrees of rotation, and it can be extremely painful. This is the anatomy of the sacroiliac joint and the nerves associated with that. And I want you to visualize this picture, because this picture tells you why lateral to medial approaches are now getting so much popularity in the treatment of the sacroiliac joint. In United States, sacroiliac joint fusion is the fastest growing musculoskeletal procedures. The anatomy of the joint, it requires you to understand that the joint has 2 parts, a ligamental part and an articular part. Keep that in mind, because I come back to that. I want to show you this picture. Now, neurosurgeon probably don't know much about this, but orthopedic surgeon, they know that this is a normal sacroiliac joint, but in no other joint this would be considered normal. I had the privilege to scrub in with one of my orthopedic colleagues when they did a hip replacement. Even the worst hip joint look smooth and much better than this. Sacroiliac joint is a non-functional joint. That is why nature allows lots of variation, and this what would be considered a horrible arthritic joint in any other joint. This is a normal sacroiliac joint, but again, you see the yellow cartilaginous part, the boomerang, and the ligamental part, which is red. Sacroiliac joint has become truly a pinnacle of spine surgery, because for a long time we neglected regular approaches. They were so bloody, so complication rich, so that we practically for 50 years in the United States we stopped doing them. But I want to tell you that it's practically many patients, especially younger patients, the average age of patient with the sacroiliac joint problem is 10 to 15 years younger than the average age of the patient with the spine problem. And certainly we do non-surgical treatment, but many times they fail. Among people who perform sacroiliac joint fusion, we call this a chameleon joint. The reason for that is that the pattern of the pain is identical to lower lumbar spine. There's no way you can distinguish that. And say CT and MRI, they show you an arthritic joint in a normal patient who have no sacroiliac pain, and they show it in patients who have sacroiliac problem. What that means that CT and MRI are to exclude other pathologies, but they are not to diagnose the pathology for you. And this is the pattern of the radiculopathy that you get with sacroiliac joint disease. This study is very clear. It can pretend to you the pattern of pain in the lower extremity that resembles L4, L5, and S1. And it is because of the proximity of those nerves to the sacroiliac joint, the inflammation of the joint cause a pattern of the pain in the lower extremity that is very misleading and radiculopathic in nature. So obviously the suspicion and the right history is the hallmark of the diagnostic, but then sacroiliac joint provocation tests have to be performed. I'm going to show you as well that literally we stop doing that as a clinician. Ask your patient to show where their back pain is. Often they literally put their finger on the sacroiliac joint, and if they do it twice within 2 centimeters or 1 inch from each other, we have a name for that. We call that 14 test. come to my webpage. I will share with you all these different provocation tests where you literally use the femur and pelvis to put pressure on the sacroiliac joint. And if you have a positive so-called provocation test of the sacroiliac joint, then you go to the final diagnostic, which are therapeutic injection. Radiofrequency ablation has not been very successful, but let me go to injections. The protocols are well established. You have to have, it used to be 3 injections, but now insurance allow you after 2 injections that are done properly to perform the surgery. It has to be fluoroscopic or CT guided. You have to put contrast to confirm the positioning, and you have to use a small amount, 2 milliliter or 2 cc of local anesthetic. You don't want to spread the local anesthetic and numb everything. You want to be intra-articular. You need to be in the articular, the boomerang part of the joint. But then, if you do it properly, and after 2 injections, each time patient gets 75% improvement, even for half a day, even for a few hours, while numb, they come and tell you they were a different patient. Their life, that the pain that they had was gone, but then obviously the pain comes back, and you do another injection. If 2 injections give you 75% improvement, then you have proven the pathology, and then you can do a fusion. Now, I can just tell you, this study sums it up. This is from Dr. Pauly here in Minneapolis that shows that the control group still was in pain. The surgical group, the pain fall down. After 6 months, it was unethical to continue the control group. And once they converted the control group to surgery, they absolutely replicated the result of the surgical group, and the pain dropped. This is very, very powerful study. This is the anatomy. You need to know that there is the gluteal artery, but if you perform the surgery correctly, you are literally superior and posterior to that artery. This is the anatomy that you see in the lateral view. You have to get the true lateral view of the sacroiliac joint. And with that, I mean you have to make sure that the 2 greater sciatic notch and 2 ala on both sides, they are superimposed on each other as much as good as you can. In the AP views, the regular AP view is not useful. You have to get the so-called inlet and outlet view. In the inlet view is you're practically getting a true axial view of the sacrum, and I show you how the position of the C-arm will look like. And in the outlet view, you're literally getting a true AP view of the sacrum. That is called so-called outlet view. I start using the SI bone, and that was the only thing available at that time. And then I quickly moved to screws. I did a study, and those studies are confirmed by others as well. The same size screw is 2.5 to 4.5 times stronger than the same size plug, what these plugs are. And then I moved to screws that have bigger cavity, that have windows, because they turn into fusion material themselves. And here you see the intraoperative view and the so-called lateral view. I marked the border of the sacroiliac joint. Border of the sacrum, as you see that upside down V on the skin. I close and connect with the line promontorium, the most superior posterior part of the sacrum, with the middle of the sciatic notch. And the middle of the sciatic notch is where you enter the skin. And, on the bone, when you hit iliac bone, you want to be anterior to the shadow of the sacrum, because you still have to traverse this iliac crest before you are centered on the sacroiliac joint. This is the position of the C-arm in the so-called inlet view, and this is the position of the C-arm in the so-called outlet view. We have cadaver lab and significant educational event in all the locations, especially in Bareilly, where we are going to usher the Trident system. Please, if you can, come and join us. And as a matter of fact, it doesn't really matter what you put in, as long as you stabilize the sacroiliac joint. It's like magic. Pain does go away. But you have to put more than one screw. That's the point, because one screw you still can rotate. Or I really admire orthopedic surgeons because they have such a good understanding of mechanic. We neurosurgeons, we mostly work with neural material and soft tissue, and sometimes we have difficulty to understand the mechanic of the spine surgeries, whereas this all comes natural to our orthopedic colleagues. So I don't need to explain to our orthopedic colleague, you have to put 2 or 3 screws to stabilize the joint. And that's the advantage of the so-called trident. In the trident, you put the first screw in, and the second and third screw go through the sleeve here of the first screw, and you don't have to repeat the surgery 3 times. You literally, right after you put the first screw in, 5 minutes later, you're done with the surgery. As a matter of fact, I did the 4 of these surgeries this week, and it takes in average about 20 to 25 minutes to perform the surgery skin to skin. And this is how the trident works. Please come and join us in Bareilly. We will have live surgeries and the cadaver lab exactly demonstrating that. Now, I want to show you just maybe one, these are how the picture look like. I just want to show you one more slide, and that is why we call sacroiliac joint colloquially miracle joint. I get often patients who had multiple spine surgeries and revisions, and the pain has not gone away. These patients are miserable. Some of them are suicidal, and these are younger patients. Everybody has told them there's nothing wrong with them. And we perform a 15-minute procedure, they go back to work within 4 weeks. People who have done that, they know that. We call that miracle joint because it truly performs a miracle in the right patient for the in the right situation. So I'm going to stop here. Thank you so much for giving me so much podium time. I really appreciate that, and it's truly an honor, especially it's an honor to see again Dr. Zileli, my good friend here from Turkey, and as well the new friends hopefully we made today. Please come and join us, join Avicenna Society. We have educational event across the world, and I'm going to certainly invite you to go to avicenasociety.org and join our society for our educational event. Thank you very much. I appreciate that.
Absolutely.
Thank you, dear Hamid. It was. Do you hear me?
Yes,
I do.
Yes,
I do.
Yeah. Okay. Thanks a lot. Very nice lectures. Especially the first one was incredible. I must congratulate you for making that happen without any usage of endoscopy and by a very safe intervention through combine triangle, and the OLLIF, you are using that term, oblique lateral lumbar interbody fusion, or what?
Well, I'm using oblique lateral posterior lumbar interbody fusion.
The term OLLIF. Oblique lateral.
Yeah. If you remember in one of my slides, there are different terminology. There is oblique lateral posterior lumbar interbody fusion, OLLIF, and then there is OLLIF ATP, OLLIF anterior to psoas, OATP. Then some additional people have been using endolif and so on because they use endoscope, but I think the better term for endolif is KLIF, which has been traditionally associated with transcambine endoscopic lumbar interbody fusion. It's still transcambine. And so, but when I refer to, when I talk OLLIF, I'm referring to transcambine approach. When I use the term KLIF, I'm talking about the truly endoscopic version. And certainly, sometimes a confusion about the OLLIF ATP, but then that is what I do. I always use OLLIF ATP, anterior to psoas. These are, which is not transcambine, which is anterior to psoas, and is not transpsoas either. Obviously, the transpsoas approaches are so-called direct laterals, like XLIF, like LLIF, or in my case, I use the term MIS DLIF, MIS direct lateral lateral lumbar interbody fusion, DLIF.
Yeah. But my question is, you are making a monitoring, and this monitoring is EMG monitoring. Is it EMG?
No, it is both EMG and trigger EMG. Trigger EMG is literally like in a spine surgery. Most of you guys are maybe don't do trans or intrathecal work, but we neurosurgeon, we do a lot of intrathecal work, and we are familiar with direct stimulation of the nerves. What we do here, we have electrode in the leg, and we put electricity 3 milliamp on the tip of an instrument, and then we give electrical stimulation in that area. If you're close to a nerve, you see specific muscle groups in the leg based on what level you're working, getting activated. So it is EMG during the surgery, but for the approach, we use so-called trigger EMG, where the machine waits to listen, you send a signal, and then you wait few milliseconds, and then you listen in the legs. If you get signal from specifically muscle group, you practically stimulate the nerve. But here, you don't want to see that the nerves are not stimulated. You give electricity, and you don't want to see any stimulation of the muscle groups. Then you know you're far away from that nerve root.
Sensory problems or neuropathic pain after that intervention, because it's as I know, it is more common with the transfemoral endoscopy, and then you cannot see any response in EMG.
Yes, this is like any other procedure. We have published numerous papers, and our 1,000+ paper is coming out soon. In the learning curve, the risk of initial nerve irritation, I call it, we categorize the nerve problem in two categories: nerve irritation and neuropraxia. Anything with the muscle weakness 3 of 5 worse, we call neuropraxia. No, number one, I did publish about 7 years ago a 300 series, and our 1,000 series is coming out. In the learning curve, the rate of nerve irritation is between 8.5 and 12.2%, but most of that is a numbness on top of the left foot. As others have published their data, this is temporarily. After a month or two, they all get better. In my study, one patient in 303 patients, after a year, still had significant nerve damage. So practically the rate of permanent neuropraxia after OLLIF procedure, if you perform it the way I perform, is 0.3%. Because we had one patient in 303 patients that still had, after a year, still significant symptoms. So considering that most of literature shows after TLIF and PLIF, that rate as well is between 1 and 3%. We seem to be under 1% in the after 1 year follow-ups.
Okay, there is one question from the audience. Dr. Harshat Tarek is asking, what is the risk of dural tear?
That is a very good question.
Did you had to convert?
Now, first of all, let's talk about the risk of dural tear or dural. Okay, so the risk of regular surgery to have dural tear in literature is between 5 and 7%. This is what literature says the risk of dural tear is. But in transcambina approach, you are completely extra canalicular, meaning that the entire cambine triangle is extraforaminal. So for that reason, the risk has been zero. I had not had single durotomy because you are completely outside of the foramen, extraforaminal. You're far away from and that is another important thing. If you, God forbid, you have a bleeding, which I had 4 times, the bleeding is in the iliopsoas muscle in the retroperitoneal space. It's not in the canal. So the rate of intradural hematoma has been zero because in a true surgery, you are not opening the canal. you're all extraforaminal, the same way that the risk of OLLIF ATP should be really minimal for durotomy, except if you're approaching way too close to the thing. Knock on the wood, the rate of durotomy has been 0.
Thanks a lot. I have no other.
Thank you very much. It has been truly an honor to be with you.
Thank you very much, Prof. Abbasi and Prof. Zilili, for the time and support for the ACNS webinars. We are extremely grateful to both of you. So now we'll move on to the second session, and I'll hand this podium over to Professor